Socialist, but apparently they were pretty close to a deal, and then it all kind of fell apart over that aspect, which isn't surprising. I think that it's devil is in the detail. There's references that IDRs would be part of the solution, whether it's a threshold like the energy and commerce bill is another story.
I mean, for our guys short they're fine.
Yeah. Right. Oh, really? Right. Well, apparently the road like adds an enormous amount of deficit. Right. So I mean, just at that level, it's not started. Yeah. Yeah. I've heard from you guys at Cinebridge a few times, sort of following up.
Really?
Yeah.
Moby.
Yeah, Moby in particular is the one.
And Bill and Shan are pretty bright.
Dude, the guys you put in the room are all really sharp. It was good to be next to Lauren when we were together because, you know, I've got a lot of like the political finger on the pulse, but like the policy details. I mean, that's that guy's bread and butter. So
That's what we tried to do.
Yeah.
To get everyone to invite us. We were looking for another day, November 7th. Before we talked, we were going to meet
Oh, really? Well, especially after
they realized,
yeah, right after.
We tried telling them, like, no,
Hey guys.
Yeah.
They have seats, but they're further in.
Yeah, how are you? Easy. Thanks for good shows too. Is that for anybody who's at the breakfast? Okay.
That's great.
Joe Mustard.
Well, I guess I did run across
Yeah, so we're like 90 the building is all started.
Yeah, on the pretty corner.
Okay, yeah.
No, I'm like just working. What about you?
So I'm courthouse.
Oh, alright. Yeah. Easy enough for you.
Steal the shirt off.
Right. Yeah, I'll see you there. I mean, if it's too crowded, I might not see you. I actually tried to go down there to walk. I heard it. You could get in anyway. Relax the bullpen was all the way 150 yards long. Then we took a mission after that. It was 2 city blocks long. And we went all the way to South Capitol and then a block up South Capitol. And there was this big party, like right in that square, right where Rockets are.
So like that
There was a live so we went in there, you could actually get in. We were like here for like 25 minutes. And we were like, we hadn't even gotten one beer, like for the baby yard for an hour. And then like, we should probably just leave this part of
We've got like, yeah, we've got so many different
we got a couple of So stuff like that. I'll get that. What about you when you try to
the people in the White House, I won't know.
Right. Yeah. Right. Oh, you are? I guess it comes from.
I think the original plan was for
Yeah, it's nice to be able to deliver checks. Yeah, yeah.
Well, it's all good.
Yeah, that makes sense.
It was all of us. 2 years.
2 years? Yeah. Jesus Christ.
Elected January.
Yeah. Yeah. She's good. Yeah. Latest thing, she just turned 2 recently. We're gonna scooter for her birthday. So she's like a machine on this thing. It's a lot of fun.
Yeah, you guys up here right away?
Every day before daycare, I'll like follow around.
Senator, I think we went there. I think we went there. No? Good morning, everyone. Welcome to the Bipartisan Policy Center for. I'm sorry. And let me introduce Bill Hogan.
Then I'll introduce you, Jason. I guess we got our signs mixed up. Good morning to all of you, and particularly to you exhausted but probably relieved Nat fans out there. Welcome to BPC this morning. By the way, in the spirit of bipartisanship, let me just say to the Astro fans, if nothing else, it's been a very exciting series, and I really enjoyed it myself. I'm Bill Hoagland, Senior Vice President here with the Bipartisan Policy Center. I have the pleasure of working with our economic and health teams on various public policy issues. We're here to talk about one of those topics many of us have experienced, and that is surprise billing. I don't think I need to tell this audience too much about what that means, but when a patient receives a care from a doctor, an ambulance service, or a hospital outside the insurer's network, and the doctor, ambulance, or hospital subsequently bills the patient for that amount over their insurance, what their insurance will cover, it's the surprise bill. Staff asked me to relay a personal experience, since we've all had personal experiences with this. On the birth of my first grandchild, my daughter-in-law at that time and my son lived in Taos, New Mexico. And if you know about New Mexico, it's a long way. It's a spread out state. She had complications, and so she had to be flown by an emergency air ambulance from Taos, New Mexico to Albuquerque. A relatively short flight. When the bill came, my son said it was $60,000. I told him, surely, Peter, you've got the decimal point in the wrong place. And he showed me the bill. No, it was $60,000 out of network on the ambulance. We were able to eventually work it out, but even if you've not been subject to a surprise bill, I understand research today indicates that we are all impacted, and that surprise billing results in higher health insurance premiums for all commercially insured families. So fixing this issue seems to have wide bipartisan support on the Hill, and we are honored to have 2 United States senators with us here, a Republican and a Democrat, here to discuss their approach to the issue. So without further ado, let me turn it over now to my boss, Jason Grumet, President of BPC, and he's going to discuss with Senator Cassidy of Louisiana and Senator Hassan of New Hampshire their bipartisan bill entitled the Stop Surprise Medical Bills Act. Jason, take it away.
Thank you, Bill. And again, welcome. So we're obviously going to kind of drill down on this issue, but before even getting into this discussion, you two are kind of a dynamic bipartisan duo these days. In addition to your work on surprise medical billing, You're working together on issues around paid family leave. The AMP Act, Accurate Medicaid Pricing, was actually signed, into law, reminding people that legislation actually still is happening, despite the careening democracy we all live in. You've also worked together on the CAST Act. And so I guess my first question was, like, how'd you all start hanging out together? What was the, you have a lot of obviously shared interests on a couple of committees, but...
Well, I think probably the experience that we had the most time together on was a congressional delegation trip, in February or so of 2018, that was led by Senator Graham and Senator Coons, and Bill and I were on it. We went to London, Jordan, Israel, and Greece, and so those trips provide a great opportunity for us to get to know each other. Bill's wife was along, and that was really fun to get to know her too. And that also allows you to just start talking about your common interests and common experiences, along with some exchanges at our bipartisan prayer breakfast, which also helped us both understand how much we cared about the healthcare issue and how much experience we each had in our own way with some of the challenges of the healthcare system.
And I will add, first I'll say ties that are more enduring are ties that are multifaceted.
Yeah.
Our staffs work together very well.
Right.
And so when we began this surprise medical billing, it may have been 2 years we've been working on this, but our offices and Michael Bennett's and a couple others all teamed, but our staffs work really well. Yeah. And so a lot of the preparatory work has been done, and it's tied with a bow around it and handed to us, and of course we feel great. Secondly, Maggie's attribute as a governor has been incredibly pragmatic. So I bring an idea to her, and she goes, I did that as a governor. And we saved $3 million in a small state in the first 6 months. Yeah. So I know from experience that this can work. I'm a physician. Physicians are eminently pragmatic because otherwise, if you're doing something that doesn't work, at least you're doing harm. At worst, the patient dies. So I do think that our pragmatism, in fact, sometimes I think, oh my gosh, I can't ask Maggie one more thing because I got another idea for her. But she's always very open to collaborating once more.
Senator Frist says the same thing whenever he's trying to win an argument with Senator Daschle about the pragmatism of physicians. So that resonates with us. And I also just note, and this was not an intended commercial, but your insight about the Codells we think is really important. I think now that you all just don't have a lot of time to spend together, we've been doing work on the House side getting members to just spend weekends in each other's districts. And the kind of authentic chemistry that creates, we think has been really important. So to the issue at hand, Doctor, why don't you share with us first, why is this an issue that is important to you?
Well, Bill mentioned how everybody has a personal experience with surprise medical billing. Mine is my daughter fell off the statue of Alice in Wonderland in Central Park. And we take my child to a plastic surgeon who puts a little bit of glue, which eventually falls apart. And I mean, literally kind of like, we're out of here. And we get a bill for $3,000. Now, what? Now, we're two physicians. And you were mentioning there's a former member of the House, an OBGYN, who speaks of his daughter. He's an OBGYN, he's a member of the House. And his daughter goes in to deliver and gets this incredible bill. Now, if anybody should have known what was going on for delivery, was an OBGYN who happened to be a congressman. So it is a problem in which the patient is powerless. Those who have the power all benefit from the current system. And whatever criticism you're going to have about private equity or insurance or hospitals or doctors, they do better under the current system. They do better. And if anybody's trying to sabotage our legislation, you have to look and say, they do better under the current system. Maybe they just wish to maintain status quo as opposed to taking the patient out of the middle.
And like I think everybody in this room, we all have experiences with surprise bills. I have constituent after constituent who's talked to me about it. One of them, a woman named Donna Beckman, who makes a call to her, the nurse, I think, in her insurance plan on a Sunday morning when she has symptoms that could be cardiac. They tell her she should definitely go to the emergency room. She goes to her in-network emergency room. She is run through a bunch of tests. Good news is she's cleared. She isn't having a heart attack. That's great. Bad news is she gets a bill for $1,600 because one of the doctors treating her at that in-network emergency room wasn't himself in network, and she had no way of knowing. And I think adding insult to injury, when she called her insurance plan to say, I followed your directions, I went to the in-network emergency room at your direction, they said, well, you chose an out-of-network provider. And this notion that a patient in the middle of a medical emergency has some choice is just ridiculous. And so Bill and I have heard so many accounts, the family whose son gets hit by a baseball during baseball practice, gets the ball in the face, broken nose, gets to the emergency room, in-network emergency room. The staff says, isn't it great, we have a really wonderful plastic surgeon who's here right now, and it was a very bad compound break, and he can really help set the nose just right. And they say, great, only to get a surprise bill from this, it turned out-of-network plastic surgeon for $35,000. And as the mom said to me, she was one of the people at the White House when we had the joint presser on it, as she said to me, that's college tuition for a year. Now what does my family do? So, we're a democracy where everybody is supposed to count. If everybody counts, everybody needs to be able to get health care, and everybody needs to be able to have a system where the rules of the road are clear and where they're not surprised. The whole purpose of insurance is you're not supposed to be surprised by your bills.
One thing that I've come to learn is that after the age of 12, rarely are surprises good. So this is an issue that has a lot of momentum for the very reasons that you describe. It is something that I think we all have real experience with, and that sense of powerlessness and confusion in addition to the expense. I think if you could dynamically score the confusion, I think you'd have a very different ultimate experience. But the Senate Help Committee, which you both serve on, has moved forwards a kind of basic template, House Energy and Commerce. There's a lot that is kind of fundamentally similar about all the different approaches. And I wonder if you can maybe just start out describing kind of what's the baseline where you see the kind of core agreement?
Well, the baseline is everybody agrees patients should be out of the middle of a dispute between payers and providers. That's the bottom line, especially people who have bought insurance and are doing what they're supposed to do under the terms of their insurance policy. So I think that has been the unifying force. Now, Bill and I also, after 2 years of looking at a whole lot of different proposals, plans, getting briefed by lots of different experts, Chairman Alexander and Ranking Member Murray, as you know, convened a group of experts in the Senate for people to just come in and out and ask questions. We also became convinced that having a safety valve of sorts so that when the dispute between the provider and the payer is being worked out, neither side has too much absolute power is important in terms of protecting a healthcare system that can be accessible to everybody, whether you live in rural America or suburban America, and making sure that we're not establishing such a rigid system that there are unintended consequences that can't be dealt with relatively quickly.
And Senator, drill down on it a little more, because obviously that is one of the kind of core questions. What is it about the kind of the simplicity of just everybody gets essentially kind of the in-network community fee? Where would you see that being problematic in kind of a practical sense?
First, who defines, I'm okay with that, but who defines what in-network is? Right. And so if you have an insurance plan, and by the way, there is nobody that is absolutely pure. There is no group which is absolutely evil. There is just not. I always say 5% of every group you should take out back and shoot. Just teasing, okay? Just teasing. But the point is, there's always a there's always a small group that that ends up, if you will, creating practices which implicate the rest. Let me say that first. But imagine there's an insurer who decides to give a lowball in-network rate. You pick it. Medicaid rates for a rural hospital that cannot stay in business if all it receives is Medicaid rates. Not a Medicaid plan, just a plan which chooses to give Medicaid rates. And there's no recourse for the physicians in the hospitals. Boom. They move. They leave. You shut down. Now, if we think we're going to maintain an ecosystem in which we have access in urban areas or in poorer areas, wherever they are, in rural areas, without recognizing there's financial pressures upon those entities, we lose. and allowing one party, in this case the insurers, and this is the health plan as currently crafted, so this is my objection to it, and I've been very open with Senator Alexander, so I'm not saying anything. If we allow one party, without any recourse of the other parties, to establish what that rate is, take it, leave it, boom, we're out of here, then you're going to have hospitals closed in the rural areas, and probably in the urban areas too.
And Senator, you used the phrase baseball-style arbitration, very popular idea this morning. Talk a little, just the pragmatics of how this would work. Would there be hundreds of thousands of independent claims with a new kind of arbitration system? How do you imagine the on-the-ground realities would play out?
Well, look, we don't have to totally just imagine this, because there are states where there is baseball-style arbitration that helps resolve some of these disputes. And of course, what we're talking about here for the independent dispute resolution system is a system where each party gets to put in one proposal, and with some guidelines established by the law, the arbitrator then chooses one of the two options. So one, there's an incentive for people to be reasonable with their first offer. This is not a protracted litigation style process, which is one of the things that we hear a lot of concerns raised about. This is a very simple process. New York has done this. We have differences in our bill in terms of the way the guidance the arbiter uses from the New York plan, because there are some flaws in the New York plan. But what we see is, as arbiters make their decisions and the healthcare market sees what those decisions are, people, the payers and the providers, tend to resolve the disputes without the arbitration, because they've now got guidance as to where the independent dispute resolution system is going to land when it comes to a dispute. And so we think, and there's evidence to show, that over time, providers and payers use the system less and less because they know what to expect.
It's kind of a real-time market signal.
Yeah, that's a good way to
Can
put
I
it.
just add a couple things to that? Some folks who wish to defeat any change whatsoever will speak about this as setting up bureaucracies and being very expensive. And actually, when Maggie first brought the idea to me, I thought, well, I said it. She goes, no, not at all. And she said, this is how it would work. And empirically, that is how it's worked. And I'll point out that 16 states have adopted this. So if states are the laboratory of democracy, we're seeing that the laboratories are gravitating towards this system. One more thing I'll say, for some who think that this is going to drive up cost, my assistant Mary Moody will be on the next panel, so she can get chapter and verse on this. But like the New York Department of Insurance, whoever that is, just sent out a letter saying, praising to Governor Cuomo about the independent dispute resolution process they have, and saying how good it works. And so for those who say, oh my gosh, what a nightmare for insurance, the insurance plans in New York are praising it. And there's also been a decrease in premium cost of, I think, 10%. So all the kind of objections that are on the ads in the middle of the Stroh's game, if I will, are very misleading on that.
These are interesting ads to think that people watching the baseball game understand what the letters ID and R stand for. This is, as an inside baseball ad goes, that's about as inside as you can get.
Well, maybe it sounds slightly Orwellian, so maybe they want to...
Well, so Senator, you made the point that there are some players in this discussion which are not as obvious. We think about the insurers and the providers, but the private equity hedge funds, why are they part of this discussion?
Because they're a nice boogeyman. They represent about 6% of the physicians. And so somehow that 6% of physicians is supposed to taint the entire issue. But by the way, if you want to address the issue of private equity in this ecosphere, in this ecosystem, you should pass the Hass and Cassidy bill. CBO estimates that our approach saves $17 billion. And if someone thinks that private equity is buying up a lot of ERs, therefore increasing their leverage vis-a-vis the insurer, there is an independent dispute resolution in which the insurer can bring a complaint and say, listen, we don't think this is fair. So if you're really concerned about the boogeyman that's being tossed out there, then you should adopt our approach.
Yeah. And I just want to add a couple of things. One is, these dark money ads do not help the discussion. End of story. I don't care who they praise or who they criticize. dark money advertising at a time when we are really trying to come together across party lines to solve what is a critical issue for American families and consumers across the country is just counterproductive, to say the least. And secondly, I said at the beginning, our principles are you take the patients out of the middle of this, and we don't want to reward any group that has a business model that is profiting off of surprise medical bills. And to the extent that that is fueling some of these ads, people need to understand that, and we just need to say, this isn't the way you should be making your money. Last thing I will just point out, going back to the independent dispute resolution process, one of the concerns has been, well, there are a lot of providers who are going to have relatively small balance bills, who don't charge a lot, and payers who are concerned that there would just be lots and lots of these small bills that would go to IDR. One of the ideas to deal with that is to still give access to baseball-style arbitration to these smaller billing entities, but allow them to batch their bills so that they don't have to do a separate process for every small bill. And I think that that would be a good way to deal with the concerns about how practical this is.
And so let's also start thinking a little bit about the kind of process going forward. I think there is discussion about kind of blending these different ideas. I think in the House there was some notion that arbitration would be accessible to bills over $12.50. How do you feel about those different models?
Builds on what Maggie just said. Again, we're like an old married couple completing each other's sentences. If you allow a batch, you could batch until you get to a certain threshold, but if you don't achieve that threshold, then it doesn't matter how many you batch. But if you speak to radiologists, they say, believe me, Ro Ruiz, God bless you, thank you. You move the ball forward. And I actually think that CBO is scoring their bill incorrectly. But the degree to which ours scores in a way that gives it more traction, we go with our approach. But I want to praise my House colleagues. That said, they put the $12.50 threshold in there just to get something. Well, if you can batch, a radiologist who never charges $1,250 might charge $100 14 times, then he could batch those or she could batch those and present them.
So we live in a very predictable democracy. I wonder if you all might forecast where you imagine this discussion going. I think people are thinking about, we now legislate at the end of the year on almost everything. Is there some idea that this might become part of that larger spending package?
Well, I know how frustrating it is for people when they watch the legislative process, whether it's at the local, state, or federal level, that there always seems to be this end of the year or end of session push. Human beings need deadlines, and legislators are no different. So I am feeling that there is good momentum to get this subject addressed. There is good bipartisan concern and momentum, and there are a number of other issues that we need to attend to before the end of the year. So I think it's fair to say Bill and I are very optimistic that this will get done. We got some more discussions, and we still got to wait to see precisely what the House produces as its kind of finished product on this. But we've been encouraged that the House seems to be looking more at some independent dispute resolution processes, and if we can get that product and find our common ground, I'm feeling very good about our prospects.
Senator, you made the point that your approach and all these approaches actually save quite a bit of money. We at the Bipartisan Policy Center share your kind of quaint desire to not run up the national debt by another $1 trillion. Does that create, you could be quite popular as one goes into that end-of-year spending process?
So I think both, if we decide we actually have to pay for things, again, a quaint idea, then this plus maybe some other legislation does provide pay-fors. And so that's part of the, again, momentum that could be created, the oomph, the push, you name it. And so that's certainly on our thought.
You mentioned when you think about the terrain, what are the couple of other legislative vehicles that you could possibly see kind of coming together?
Well,
the drug pricing?
Drug pricing coming out of the Senate Finance. Now, of course, there's as much opposition to the drug pricing as there is to the surprise medical billing. But that saves a heck of a lot of money. And you put the two together, and you've done something significant both for the taxpayer, for the patient, and for paying for things.
So we tend to have a rather informed audience here at the BPC, and I think we'd like to now open it up to questions. We have some fleet-footed mic runners. So if you raise your hand, we'll kind of focus on a section at a time. And I think, sir, over in the white shirt, please introduce yourself and ask your question.
Paul Heldman Simpson Partners. So thanks for holding this and thanks for being here. So I have an endgame question, which I think you touched on, but I want to pin you down. If surprise billing legislation makes it over the finish line, what is the likelihood that there'll be an arbitration mechanism, and what might that look like?
I think we are seeing movement in the House towards acknowledging that there needs to be a safety valve for providers and payers in the resolution of their payment dispute once the patient is taken out of it. I think we need to see what that final product is, and then we'll need to talk with our House colleagues as well as our Senate colleagues. But I think that there's a reason that the more people study this issue, the more they come around to thinking that having some kind of independent dispute resolution process as a safety valve is important, and I'm hopeful that that will be a part of it.
A few questions right here in the middle. Yes. Thank you, ma'am.
Hi, Rachel Booth from Kaiser Health News. You mentioned the New York model. Some data just came out about that showed that instances of dispute resolution actually increased over time. I know that model is a little bit different than the ones you guys have proposed. How are you viewing that, and how
600 to 1,000. Over millions of claims. And so the percent of those, I'm not even sure it's statistically significant, but I will accept that it's going from like 600 to 1,000. But that's over millions of claims.
Right. When you think about the number of claims there are in New York, that you have 1,000 arbitration processes really speaks to the fact that it's not being used heavily, that disputes are being resolved between payers and providers without the system. The other thing I want to be clear about is the New York system uses as its payment standard charges, which we think is wrong and misguided, and that's why our bill doesn't use as a commercially reasonable standard. And I think it's really important, and that's why CBO has scored our bill saving about $17 billion, where there's been criticism of the New York process in terms of costing money.
Sort of follow up, how useful is the New York experience to you guys while you're sort of crafting what you're doing going forward?
I think it's been incredibly useful. Incredibly useful. By the way, I think CBO is actually scoring their model incorrectly, but leave that to the side. That's how they score it. But it is an empiric basis by which we know that IDR is not abused, that it does result in lower premiums, and it's a model which has been adopted by a spectrum of politically diverse states and geographically diverse. New York, Texas, and Washington State all come to mind. And Maggie mentioned the term commercially reasonable. That is a term used by Washington State. And so everything we've done has been kind of embedded in the empiricism of what states have found successful.
We have another question in the middle, and then we're going to run over to the side. I guess we'll get these two questions, and then, sir, we'll come to you. Actually, right here, in the middle here. Thank you. Thanks, Marie.
Good morning. Thank you for keeping the patient out of this. I'm with a health system in southern New Jersey. You had talked about laboratory in the sense of looking how things are happening. New Jersey passed an out-of-network law last year. And so what we're seeing in our case is that the insurance companies are now figuring out where baseball-style arbitration is headed, and it has factored that in when it comes time for contract negotiation. So we have one insurance company that said, we're going to demand a 40% rate cut or you're out of network. And I'd be happy to talk to your staffers further about it. We have another one that is replicating that. And so the laboratory experiment in New Jersey, I think, it's our feeling that it has tipped the balance to the insurance companies. And so the caution is, as you look at that independent dispute resolution, be aware that it's going to be a real challenge to find something that's really not biased in some way. And so while we're all in network, we haven't gone through the arbitration process. There is one hospital system that's their model, is going out of network, and they went to arbitration and they lost every case essentially. The New York model, I don't believe, includes hospitals. So they just pay it. So we're watching what's going on there. And even their model allows for arbitration as well when it comes to how things might end up. So the concern is just be very careful on how you set it up so insurers and providers interact. Our preference is let it go the way it's been going. That's your safeguard. The moment you start pegging a dollar amount or a rate, you're on the way to a downward spiral on the backs of hospitals.
Can I
Want to respond to that, please?
So a couple things. I smiled a little bit because one of the criticisms by some of our approach is that private equity is going to use their analytics to game out. And so both sides kind of see each other with great suspicion. So number one. Number two, I will say that there were some smaller health plans that were paying rates that were 600% of Medicare, or 6 times Medicare rates. So whereas the average would be maybe, depending on your specialty, 1.5 to 2.75 times Medicare. And so I can imagine those folks would want to come on down. On the other hand, there were some plans that were paying less that ended up paying more. So it's interesting what you're saying, and we'd love to hear from you to see on net the pulling up and the pulling down to come towards a mean. Is that going to be a balance? Because usually the bigger plans that pay a little less, they have more negotiating power, and the smaller which pay. But the last thing I will say is that your kind of plea was to not set a rate, not a multiple of Medicare. That's why we went with commercially reasonable. Because if you have a hospital which is a very poor payer mix, that only stays in business if it charges its commercial patients a little bit more. Think of an urban hospital, lots of gunshot wounds. Poorly insured or Medicaid, which in New Jersey, Medicaid pays awfully, I just know that. So you need a better commercial rate so that the hospital's there for your commercial patients. And that's why we use the term commercially reasonable. The physician community made that case very, I think, convincingly.
Yeah. And one of the things we heard in some of our interactions with experts on this and a couple of the roundtables that we had was concern from people who had worked at CMS setting Medicare rates and said to us, you know, it's really hard to set rates. And even when we thought we had thought of everything, it turns out we hadn't. And then once you have a rate setting mechanism with no real flexibility, it's very hard to adjust. So that's one of the reasons we are so committed to a safety valve of some sort. And we think IDR is the right kind of safety valve, but we'd love to talk to you more.
So we have time for these last 2 questions, and depending on how quickly they work, we might have time for a couple more.
Thank you. Sarah Hansard with Bloomberg Law. I did speak to New York when that report came out, and one of the things that they did acknowledge is that one of the reason that the rates went down there is because before they'd made the insurers just pay kind of whatever the doctors billed. So that seems to be why their thing went down. But what the insurers are saying is, well, the problem they have with arbitration is the providers could game that easily, find an arbiter who was friendly to them and just use them. Any comments on that?
Well, I think what the providers would say is that the insurers will game it, right? So what you want to do is have guidelines for the arbiters so that they can't, this isn't a subjective decision, and you want to make sure you have a process where both sides have this incentive to be reasonable because they only get one shot at a proposed payment. And so I think the other piece of what we've heard from not only the New York process but the other IDR processes is that increasingly providers and payers have been working this out on their own.
And I'll just emphasize once more the letter from whatever it was, the Association of Insurers in New York, recently that came out that praised their system. So.
Okay, sir, you've been waiting patiently right there in the corner.
Yeah, Carl Polzer. I've been researching the checkerboard of federal and state regulation of insurance for 3 decades. So 2 questions. One is, how would this federal overlay of an arbitration fit with different silos that we have legally? For example, people imagine that all these disputes are between insurance companies and providers, but really most of the private coverage is not insured.
Right.
It's under ERISA, and it's really a dispute between a trust.
Yeah.
It's a part of a promise from an employer to an employee. And the ERISA lobbies are very, very tender about how this might intersect with the hard-fought, patient protections that were put in the 1990s. The second question is somewhat related, and it has to do with burnification. So you talk about I was watching those commercials on the baseball game, and I was the only one that was probably watching them. So they're talking about government taking over, and I think, well, what is it? Are they worried about with this? Okay, so there's a commercially reasonable standard that's put in, and it overlays the whole system. A new government comes in 10 years, it's more socialist in nature. So now when you call New York to appeal the arbitrator's decision, there might be some burnification going on. It might be a socially acceptable price. So that might be a platform for a national sort of rate setting system. I don't know what they're getting at, but two questions. But it really has to do with the structure of how you overlay this on the checkerboard.
I will note on behalf of our senators that their incredibly talented staff will be on stage here shortly, who might be able to also dig deeper into some of those complicated questions.
Bill, I don't know if you want to go
I'll
first.
take a pop. So obviously state plans would be regulated by state regulation, ERISA by ERISA. By the way, implicit in what he just said is we know nothing, just rely upon the staff. We're.
I was trying to be charming about it, but go ahead.
But one thing that we have proposed is that a insurance card would indicate, is this a state plan or is it an ERISA plan? So we do think that that distinction should be made to the provider and to the patient. And secondly, as regards the rate setting, as Maggie explained this to me and as I comprehend it, this arbiter is independent of the federal government. We are not setting up a huge bureaucracy. Right. So it isn't as if, now if you're saying that one of the plans which would include as its setting a multiple of Medicare, yes, that would be effectively rate setting by CMS. But as we conceive our plan, it is quite independent of whatever the political process is in sway.
Yeah. And I think it's just really important, to your point, for people to remember, and I know this audience knows it, but that 60% or so of Americans are covered by employer-sponsored ERISA-regulated plans. And that's one of the reasons that we felt action at the federal level was so necessary, because the states can't regulate those plans. And that leaves 60% of Americans getting surprise medical bills, even if their state has passed legislation that outlaws it. So we don't want to interfere with the state's rules in terms of state regulated plans if they've already addressed surprise medical billings that way, but we do want to make sure that all Americans know that as patients, they're going to be out of the middle of this dispute. I mean, that's the bottom line here. Patients don't belong in the middle of a dispute when they have bought their insurance and they have followed the instructions to go in network.
So we have two other folks who have indicated a desire to ask questions. Maybe we'll have both questions asked, and then we'll let the senators respond, and in doing so, offer your final thoughts. So, sir, and then still right in here in front.
I appreciate it. Shay McCarthy with Thorn Run Partners, and thank you both senators for your leadership on this incredibly complex issue. I know that for stakeholders who had concerns with the median in-network rate proposal, they were optimistic not only with your bill, but also the negotiations that we understand that you've been having with Senator Alexander. And given his leadership as chairman, obviously he'll be an important voice on this issue. I'm wondering if you could just speak to briefly sort of where those negotiations potentially stand and what sticking points that you've had in trying to reconcile some of your ideas with the bill that seemed to win the day in the committee process.
So let's add this last question and then ask the two of you to share your final thoughts.
So my question was building upon the question that was asked over here. The state laws, like in New York, don't cover the ERISA plans. So I was just wondering how the arbitration process might work with a provider and a self-insured employer that might be smaller, maybe have 300 employees. Wouldn't that kind of be a logistical nightmare for a smaller self-insured employer to go through that process?
Maggie, I take the first, you take the second.
I was going to say, yeah, you take the first, I'll take the second.
So Alexander has been wonderful to work with. And he has incredible concerns about private equity groups buying up every emergency room practice in 100 miles and getting that kind of, I don't know if it's a monopoly or monopsony, but that power to set rates. And he's had very good critiques, his staff has as well, and we've attempted to respond to those, and we actually think our proposal is better because of it. Now, that is not to say that we have persuaded him, but it certainly has enlightened us as to concerns. And for example, we've made an effort to set more guidelines for the arbiter so that the arbiter is being fair, not being gamed, and put in certain provisions that if you have a concern about some very sophisticated outfit pinging in an effort to drive up, maybe say, okay, in certain situations you can only bring every 6 months. So we think we've tried to address it. I can't tell you that we've convinced him, but I can say that we've worked hard. And I'll just finish by saying this. What you just mentioned is a Republican conversation. Maggie's had conversations with Patty, and so I will say this is one of the few bills, and since I've been in the Congress, in which it is on bicameral, it's on both sides of the issue, there are Republicans and Democrats. It's really kind of a strange thing. My observation is if you can't throw abortion or guns in, you can actually get strange bedfellows. But on our side, that working relationship has been very collegial, and I think is going to end up with a better product no matter where we end up.
And I would add that the discussions we've had with Ranking Member Murray, and I know the discussions that she and her staff and Chairman Alexander and his staff have had have been really important to this process too. It's been, Lamar and Patty have a reputation and a record of working really well together and being strong negotiators for their position, but then getting to practical solutions. And we are very hopeful that we will get there with this one. And I will also add to the shout out that Bill has given to our staffs, because Mary and Ian, thank you. You have really led a lot of across the aisle discussions about this, and some bicameral discussions as well, and we are really grateful. To answer your question, at the end of the day, an employer with 300 employees, which in my state is a really big employer, is in a much better position to deal with the issue of an unpaid balanced bill than an individual employee in that situation is. I mean, that at the end of the day, that's where we have to land. I am a lawyer, I am a senator, I'm a former governor, my husband has a doctorate in education, we have a son with complex medical needs, and I can tell you there are times we get bills and we have no idea who's billing us for what and what our obligation actually is, given the intersection of commercial and government payments for our son. The thought that an average employee is going to be able to navigate this, to me, seems really misplaced. Employers who are running their own self-insured programs are going to have professionals helping them run that. And the system that we are establishing here is a system that should be simple, because again, it's not classic litigation arbitration, it's baseball-style arbitration. Each side gets one offer, incentivizes them to be reasonable, and what we know is that over time, they stop using the arbitration system and they just work it out among themselves, which is what they should do without the patient being stuck there in the middle. Final thought is thank you to the Bipartisan Policy Center. Thank you all for being here. Thank you for your commitment to bipartisan problem solving. When you really think about our founders' ideals, it wasn't the idea that we were all going to agree on everything that inspired them. It was the idea that when you have healthy debate and disagreement and different views, that actually the compromise that is forced by our system will produce new, creative, better ways of doing things. And so I always say it's not about whether you argue, it's what you do after you argue to actually get to a solution. And you guys really lead in that space, so thank you so much.
Thank you. I think the experience of this last 45 minutes is incredibly encouraging to me, because the ability to have an actual evidence-based conversation about a real concern, the fact that the two of you have this kind of trust relationship, Senators Alexander and Murray, and we can't help but mention the fact that you have a staff who are also working together, is the way that we have constructive collisions of ideas that produce durable outcomes. So it is a real pleasure to have the morning with you, and thank you both for your work.
Thank you so much.
We now ask our second panel. You can.
Thank you, Senators. Thank you, Senator. Appreciate it very much. Appreciate it. Thank you, Senator. Let us now turn to a panel of, we already heard about it, in the know congressional staff that have been working on this, both from the House and from the Senate, and moderated by an equally knowledgeable person, Sheila Burke. So Sheila and panelists, please come to the stage. Sheila will do the introduction of the staff here. Sheila is the strategic advisor with the Baker Donaldson, and by professional training, a registered nurse. She has a lot of vast knowledge of federal policy and programs, drawing from a long, distinguished career in private and public sector. Besides her role there at the firm of Baker Donaldson, she also continues to be a faculty member at the JFK School of Government, Harvard, and she teaches health policy courses there.
Take it away.
She spent nearly 20 years in the U.S. Senate, rising from staff on the Senate Finance Committee, responsible for Medicare, Medicaid, health care programs, ultimately becoming Chief of Staff of the Senate Majority Leader Bob Dole, one of the founders of the Bipartisan Policy Center. This one I'm jealous about. She was elected as Secretary of the Senate, which you may not know, which carries with it the ability and privilege to walk onto the Senate floor and into the Capitol at will. Something I wish I still had, but I don't. And she followed her Senate career as Deputy Secretary of Chief Operating Officer, Smithsonian. Finally, and most importantly, she's a very valued senior health advisor here at BPC, and I can say a longtime colleague and friend. So Sheila, take it away.
Great, thank you, Billy. Good afternoon, or good morning. We've had a terrific discussion already this morning that I'm hoping we can build on. I will note, as Billy did, both of us having been former staff, the note made of the importance of the staff in this process. And I can't think of a better description of their contribution than their willingness to work together. That was always a critical element for much of the work we did in the 80s and 90s and 2000 in trying to achieve a result on complicated issues. And so we should begin by, again, thanking the staff for the work that they have done and the fact that they're going to be left answering the questions that their bosses didn't quite get to. It's an interesting question, and I'm going to quickly introduce each of them so you see sort of the sense of the background and the difference in their positions and how they approach it. And we're going to try and probe a bit, particularly where the House is. We've had a great opportunity to hear from the senators about where they are and what I refer to as the upper body. We'll have the opportunity to hear how the House is approaching this as well, and where there may be opportunities for, in fact, conclusions to be reached yet this year. We have Noel Ahern, who's a professional staff member of the House Energy and Commerce Committee, and has really some interesting background in terms of having worked in Greg Walden's office, and we'll bring him. We're very sad to hear of Greg's retirement, but will help us think about how the House has approached this and how they might approach a compromise. Adam Buckaloo, who's the Deputy Health Policy Director of the Senate Help Committee. Obviously, we've heard a great deal about where Senate Help is and the work that they are doing. He, of course, advises Chairman Alexander and will be able to help us understand where the chairman is. Obviously, Senator Cassidy has noted the importance of the chairman's involvement in this, as well as the ranking member. Again, he served on the House side and so has some appreciation for the House as well, having served for Congressman Mullen from Oklahoma for a period of time. So an appreciation for both sides, and also for Greg Harper on the House side. Colin Goldfinch, who is a senior health policy advisor at the Senate Help Committee as well, and works for Senator Murray. And so again, we'll have the opportunity to hear from a bipartisan perspective how those two members who seem to work so well together, Alexander and Murray, have approached this and how they view this alternative to essentially what the committee did. He also spent time as a Winston Fellow, a program many of us are aware of, and on the Senate Finance Committee. So he has some sense of what the other committee in the Senate has and how they think about this. Mary Moody, who is the health policy advisor for Senator Cassidy and was referred to frequently by Senator Cassidy as the source of all knowledge. So we will refer to Mary to help us navigate through Senator Cassidy's point of view and the issues that they've touched on in terms of arbitration, issues with respect to ERISA and so forth. And then finally, Samantha Satchel, who's a professional staff member of the House Energy and Commerce Committee, who works for the Democratic side and covers a host of issues, and also had some experience at George Washington University in their health program, and can approach it, again, helping us understand how the House approaches this issue and how they might approach coming together with the Senate. As noted by Senator Cassidy and Senator Hassan in the course of their opening comments, this is one of those issues about which people care deeply. We heard a number of very specific examples of, in fact, what the public faces. We all have a personal story. Billy had one. I had one as well. My daughter, when she was 1.5 years, decided to reach up and grab what was a hot cup of tea and pour it down her chest, and ended up in the burn unit at Children's Hospital. As is often the case with all of us, we really don't care what the cost is. We just want it dealt with. But it came as something of a surprise when we finally got the bill. But that faces an extraordinary number of people and families in terms of caring for their families and surprises they don't expect. It's an issue that has strong views from the stakeholders, and we heard about some of the stakeholders this morning in terms of payers and providers and patients, in terms of how we might reach resolution on this issue that have very strong views. And there would appear to be the elements of a compromise between the House and the Senate, but we have yet to know what those elements might be, and within the Senate itself, within the Help Committee. Obviously not here today is anyone from the Senate Finance Committee. And so, one of the issues, of course, are the federal programs, in addition to how this deals with the private programs. And so, some sense of how Senator Grassley and the Finance Committee members, of course, we have 2 members of the Finance Committee, but how the committee, which has not really looked at this issue, might also consider it. And some of the elements which are really common between both the House and the Senate, and between Senator Alexander and Senator Cassidy and Hassan, and which of those elements are likely to survive the process, which are likely to pose the greatest difficulty in trying to reach a resolution. So we're going to probe that a bit today as well. But I'd like to start, if we could, from the House. Since we had the opportunity to hear from Senators Hassan and Cassidy, the impressions from the House in terms of how you might imagine the House sort of reviewing what has now been proposed in terms of Senator Cassidy's legislation, where you see there may be common elements, and also where some of the disagreements continue to exist on the House side. So let me begin with our House colleagues. Nolan and Samantha.
Sam, do you want to kick off?
Carry on.
Sure. So I think on the House side, we had released a discussion draft in May that was quite similar to what has come out of Senate Help in terms of it having a benchmark tied to the median in-network rate. We received a lot of feedback, as well as had hearings and spoke to our members about what might be good additions to the policy to get stakeholders and members to a place where they felt comfortable. I think one of the key changes that we made first was tying that median in-network rate, choosing a base year, which is 2019, and growing that rate with CPIU. We felt like that was a way to make that out-of-network payment grow in a more predictable way and give providers a sense of predictability that there won't be this significant downward pressure from insurers year over year on that rate. So that was one key change we made. And then as we went through the committee process and marked up a bill, we came to a compromise with our members. Some of our members, as mentioned, Congressman Ruiz, who had a bill which heavily relied on arbitration, such as in the New York model. And we came to a compromise where Congressman Ruiz offered a bipartisan amendment that was accepted that would add an arbitration process on the back end. The difference there being that we felt it should be a much more limited process so as to not create a system where suddenly you have the vast majority of claims going through this process. We felt like that would create a lot of burden and just not really be the most transparent way to resolve these disputes. So in terms of similarities between what Senator Cassidy and Senator Hassan has done, I think there are a lot of similarities between the bill that ultimately came out of Energy and Commerce and their legislation in terms of both relying on a median and network payment, both having this backstop at the end. I think the key areas of differences being how we've tied the benchmark to CPIU, as well as the fact that we've included a threshold for the claims that can go into this arbitration process. So in our bill, if the median in-network payment is above $1,250, that becomes a claim that could go through this process. And we felt that was important to ensure that it was really a process used for the most high-cost claims and not a process that becomes sort of the new standard for how these disputes are resolved.
Sam, I wonder if you might take an additional moment. Senator Cassidy talked about this question of someone with a number of small bills, a radiologist or whomever, although I've never met a radiologist with a small bill, but should we? How you would respond to that in terms of, they're excluded from the process as you've designed it. Has thought been given to how you might capture those situations as well?
Again, I think from our perspective, thinking about the costs that go into arbitration, I mean, we've seen figures, even though it's not a litigation style arbitration, it could cost you a couple $100s just to get in the door. Is it really worth having a system where that radiologist is paying $200 to argue with the insurance company or a large or a small employer over a $300 bill? We would argue no, and I think that's why we landed where we did with the threshold.
Okay, thank you. Nolan.
Sure, yeah, I think to start out, Congressman Walden looked at what Oregon had done, talking about state laboratories, and they used a median and network rate to solve balance billing or surprise billing disputes that, for the plans that they could actually regulate, again, 50 to 60%, depending on the state, is under ERISA and can't be regulated by the state insurance commissioner. So we started there and got a lot of feedback from providers, insurers too, stakeholders across the industry, and kind of came to agreement with Dr. Bouchon and our committee and Dr. Ruiz on their side of Energy and Commerce on a good IDR backstop that allows for some negotiation after a median and network rate is paid. I think, Congressman Walden's view is that we can continue to look at different ways to make that work, but that we do feel it should be a fairly limited process, that really, if a provider is going to bring a claim to arbitration, it ought to be based on sort of the quality of care or additional factors that can be considered, not a rate that has been artificially inflated for the previous years based on their ability to surprise bill patients. So we do have concerns about the growth of healthcare costs leading up to something that we're going to legislate, and we don't want to bake those costs in necessarily. But we continue to have conversations with Mary and others, and we'll keep those going and trying to get this law passed.
So let me turn to the staff members of the committee before turning to Mary with a couple of questions. Buck and Colin, your sense of where your bosses are, what you anticipate in terms of trying to move this forward, trying to bring resolution around this sort of one big issue, which is the arbitration issue. And I will probably come back and ask all of you to project what you think the likelihood is of completing this year as we get towards the usual end of year sort of bundling everything together. Obviously, the cost issues and the savings have an opportunity to be moved forward. But let me ask you, where are the bosses? Where are Alexander and Murray on these questions?
I'm happy to go.
Sure.
So Chairman Alexander has clearly made this a priority. I would say, to a certain degree, he views this as a legacy issue as he's retiring at the end of this Congress, and is very passionate about making sure that the patient is taken care of first. I think that is something that is often said at the front end of a conversation, but is quickly followed with a "but." We have a preference in how this is handled. I mean, you can look at the advertisements during the World Series, and You don't see patients who are getting balance billed with enough money to run an ad during the World Series. You're seeing people who are clearly benefiting from the existing market failure. So we do have concerns with the arbitration proposal, and I think it's because of the potential inflationary effect that can have in the healthcare system. Senator Cassidy did a great job of outlining some of the benefits of arbitration, but within some of those same reports, you can find where it has inflated healthcare prices. For example, he mentioned the recent report in New York that showed that it has saved the healthcare system a couple of $100 million, which is wonderful, but that same system relies on the 80th percentile of billed charges as a consideration for arbitration. And a recent report found that as a result of that, even though the issuer is winning 50% of the time and the provider is winning 50% of the time, when the provider wins, it's actually 8% higher than the 80th percentile of charges. And when the plan wins, it's only 11% lower than the 80th percentile of charges. And I think we can all agree billed charges is not a very scientific number. It is very arbitrary. And if you select the 80th percentile of that, it on the surface has an inflationary effect. Now, that's not only important to Chairman Alexander, but President Trump has outlined 4 principles for surprise billing. And one of his principles is that it doesn't increase healthcare costs. So that's important to the administration just as it's important to us. Now, saying that, I do think that it's necessary for senators to take a look at the House proposal because it is very realistic that this is a bicameral conversation now. And so we are educating ourselves on the merits of both sides of this argument. I'm in constant conversation with Mary. DC would have you think that these are very contentious arguments, but I would say amongst the staff, they are very practical conversations about help us better understand where your boss is coming from on that. Okay, if he can't get this, what is something else that we could probably accommodate? And those conversations are ongoing. I will say I have a very unique perspective here. I just started for Chairman Alexander about 5 weeks ago, and I transitioned from Ranking Member Walden's office. So this group right here had meetings on the schedule, and one day I showed up on behalf of Ranking Member Walden, and the next day I showed up on behalf of Chairman Alexander. So it has been a lot of fun to kind of see this from both chambers as well as both sides of the issue when it comes to arbitration.
So let me pause on that and just ask the question about billed charges. I mean, this is something Senator Alexander has commented on Senator Cassidy and Senator Hassan both commented on the challenges with using charges and the challenges as you described them in terms of being inflationary. Mary, thought that was given to that, and on the House side, your thoughts in terms of sort of what that base might be in terms of an arbitration structure?
Sure. So as my boss alluded to, we worked on this for a couple years by now, and we took information from both sides of this argument. And what we did was come back with, we heard from the providers, they all wanted billed charges. We heard from the payer side that they wanted, some percentage of Medicare or network rates. And so what we tried to do was take the best ideas from both sides, marry it together into a system that would protect patients and also, ultimately not be inflationary on cost. I think a deliberate part of that was the way in which we directed the arbiter to look was not to build charges, which is the basis of a lot of the Brookings report, looking at the New York model, but was to the actual contracted rates. And so in turn, we've seen the CBO score come back on our bill as saving about $17.5 billion. So instead of being inflationary, ours has actually been deflationary on cost.
If I could add one thing, I think Mary's absolutely right about that it would have savings to the system. And regardless of if you think CBO is right or wrong, I mean, CBO is, a classic punching bag in Washington, D.C. They do tremendous work, and they have very unenviable jobs. I will say that if you look at the delta between the bill that passed the Help Committee, which was roughly $25 billion, Colin, the bill that passed Energy and Commerce, which was, I think, 21.9, if I'm not mistaken, and then the Cassidy proposal at 17.5, it is clear that economists believe that arbitration does have a cost to the system, right? Because the HELP bill does not have it, the Energy and Commerce bill has a hybrid system, and then the Cassidy bill takes a different approach. So it's clear that each step of the way, when it's added, it reduces the savings to the federal government.
So I want to give Colin a chance as well on behalf of Senator Murray to sort of comment.
Yeah,
as well.
sure. So I think, the reason this is a priority for my boss, for Senator Murray, is sort of the same as you've heard from other folks on the panel and from Senators Hassan and Cassidy this morning. I think, one of the reasons especially that, she hears from her constituents about it is that it's a surprise. It's so unpredictable that, regardless of the size of the deductible in your plan, the breadth of the network, people are always at risk. If it's an emergency situation or there's a substitution and an anesthesiologist in a surgery, always at risk of seeing these types of bills with no predictability on how large they are. And I think that, the fear of that sort of risk really undermines the whole point of having health insurance, which I think is part of the reason that, so many people come to this debate so passionately. So when, she started working with Senator Alexander on this, all these months ago, her priorities were that patients be protected, but that the protection for patients not only means that they're protected from out-of-pocket costs that they can't predict, but also premium increases, that we're not just sort of like poking the balloon in one location to see it kind of bulge out in another. I think the second for her was to make sure that state solutions that have been enacted are protected as well. As folks know, Washington State recently enacted an IDR approach using a reasonable commercial amount. As was mentioned earlier, she wants to make sure the state can still use that system. And finally, that there's a way to, strike a balance between, the needs of providers working in the system and the needs of payers who are paying on behalf of their enrollees. So when we first started the process in the HELP Committee, she and Senator Alexander put out 3 different options in the discussion draft before the committee marked it up. One was a benchmark payment, one was independent dispute resolution, and then the third was a more regulatory approach, an in-network guarantee. And I think, when she and Senator Alexander sort of looked at the feedback, as there were many hundreds of pages of comments that they received on those models, she heard very strong concerns from providers on the in-network guarantee. That was their least favorite of the 3 approaches. And then, also strong concerns, I think, from Senator Alexander within his caucus and also from the White House about arbitration. And so with the benchmark being everyone's not least favorite approach, and resulting in sufficient savings to make sure that the Lower Healthcare Cost Act that passed out of committee would actually lower healthcare costs. That was sort of the option that I think she and the chairman sort of felt met the sort of like standard parameters of the bargains that they have a history of agreeing on. With that said, I think she's committed to Senator Hassan to keep working to improve the legislation, and I think she is very serious about it.
So I want to probe a bit more into the arbitration issue, although I want to leave time to talk about other issues that may come into question as well. But in terms of the arbitration issue, one, what is commercially reasonable? What does that mean? Who defines it? How's it set? And who chooses the arbiter?
So, go ahead. Yeah.
Okay. I was just going to respond because we put that language in our bill, and we specifically define it in such a way to say it would include contracted rates, actual negotiated rates, with the explicit description that it would exclude provider charges. I think we could further add to that and say, it would exclude Medicare, Medicaid. So that would be a definition we put in statute.
Okay.
If I may, I wanted to respond to a couple of pieces just on the cost of arbitration, White House, et cetera.
But you don't get away from not answering who chooses the arbiter, so we'll come back to that.
Oh, I can answer that too. I mean, the way in which we set it up is it's a random assignment. I think there were some concerns brought up that it could be gamed. You can consistently go to the arbiter that you want. I think you can address that by saying it's a random assignment, or both of the parties have to agree to an arbiter. I think that could prevent some of that bad activity. In terms of the cost of this system, I mean, certainly, my boss was concerned about that as well. He doesn't want to set up a system that's going to just inject administrative burden into it. I think when you look at, as Buck pointed out, there's really not that big of a delta in terms of the savings when you look at HELP bill, E&C bill, our bill. I think we tried to do it in such a way that it would streamline any sort of administrative burden associated with it. Frankly, even some of the reports that came out today in Axios was talking about some of the folks that are involved in doing the, on behalf of payers, for example, doing the arbitration in certain states. The report also added that even just in pinpointing what a benchmark is, there would be some administrative burden in coming to what that figure is. So I think either way we go here, benchmark, dispute resolution, there's going to be some added administrative burden. I think what we're trying to do, and even, I'll just point this out, one of the conversations we had, even if we were just to overlay on top of a system of saying, just to make sure that the provider is getting the median in-network rate that they're supposed to, according to, even if we do a benchmark, if we were just to tack on a system of sort of oversight to make sure that the provider is actually getting that rate, then there would be costs associated with that to say that the provider, the lion's share of the costs associated with that in sort of a dispute resolution system would be devoted to going to give the provider what they were rightfully owed. So I think it speaks to there is a need for some sort of outside party here. Sorry,
okay.
I want to echo a little bit of that.
Absolutely.
So Ranking Member Walden definitely has all of those same concerns. I think agrees, with Buck's sort of breakdown of the cost of the different options. We went through all of this in the legislative drafting process. And although the delta is not significant in one sense, I mean, we have a tendency to throw around like billions of dollars like it's chump change in healthcare. But the $3 billion difference between our E&C pass bill and the HELP bill at 25, and then the additional 4.5 or 5 down to the 17 figure for Cassidy's bill, is still significant. I mean, it's not insignificant. However, when we made the decision that Greg was comfortable moving forward with a compromise on an IDR backstop, it's because we do have concerns about rural access and provider shortages and insurers driving down rates to a degree that is not just making up for what may have been inflationary over the past few years, but to an additional degree. And so we have to balance all of those concerns. And that's why I think we were comfortable landing with the compromise bill that got unanimous consent out of the Energy and Commerce Committee, which is a pretty significant step.
So let's talk about the states, and I want to leave some time for questions. And the issue of preemption, and how, given the number of states, 16 or 20 states, however many it is, that have chosen to proceed ahead and put in place changes within the state. The issue of ERISA came up, and that is the controlling of ERISA plans, which the states don't have. But clarity around the preemption issue, that is to what extent, if the states in fact have put in place plans, how does the House bill, how does Senator Cassidy and Senator Hassan's bill essentially accommodate or address? Sam, in terms of the House?
Sure. So for the E&C bill, in terms of preemption, states have the ability to regulate a certain group of plans, fully insured plans. We would continue to allow states to regulate those plans if they have surprise billing laws, and to allow them to come up with or maintain the method that they have to determine how that payment, that out-of-network payment is determined. I think on the patient protection side, though, we want to make sure that there are uniform patient protections. So if there is a state, and there are some who, for example, maybe their law only applies to emergency care or certain types of plans, that state would have to come up to the federal standard there in terms of the patient protections. But in terms of determining what that payment is, they could still come up with their own method.
Great. Mary?
I would actually say in terms of the HELP approach, we are largely in sync on that, and that we basically, if a state has already enacted their own sort of surprise billing protections for patients, that they're able to continue doing that. And so our, whatever system it is, would apply to patients who are in federally regulated ERISA plans, or to those patients who are in states who have not done anything on surprise billing.
Okay. Okay, yeah.
Just jump in. I think like the various bills are not only sort of like consistent with each other on how ERISA preemption and state regulation of insurance works, but they're pretty consistent with how these things work now in other areas. So basically all of these bills set a common protection for patients across the country, so that no matter where you live or no matter what type of commercial insurance you have, you know that you have the same level of protection. That if states in their particular markets know that there's one system that's going to work better for them, they have the ability to come up with this sort of like back-end mechanism for resolving payment. And then, because ERISA plans may operate in more than one state, they'll know that they have a sort of consistent system across states.
The country.
So it's kind of consistent, in all of these bills with the way insurance regulation kind of works on anything else.
I'm going to open it up for questions, so raise your hand and the mic folks will zoom around. But let me ask each of you while we do that. What are the other big differences? Where do you see the likelihood of disagreement between the House and the Senate? And even within the Senate, what do you think will be the issues that will cause the greatest challenge in terms of resolution coming to closure? Mary, you want to start? We'll just come right down the line.
Sure. So, I mean, I think it's been pointed out in terms of the differences between where our boss is at and where the chairman is at. I think with the House E&C bill, I think some of the, I think my boss rightly acknowledged, we thought it was a really good step and towards, where we're coming from. I think the concern continues to be around that threshold and just worry that there might be certain classes of providers that are just unable to access arbitration. And I think it might be between, I understand your point of there's a certain fixed cost associated with going to arbitration. Obviously, that also assumes if you lose. But there's certain fixed costs, but there will be a large chunk of providers who are just caught between, underneath that threshold and then over the fixed costs associated with arbitration. And some of the data we've seen would indicate that emergency docs, only about 2% of their claims ever go above $1,250. I've seen from radiologists it's less than 1%. So I think that's where the rub is, and I think we talked about using batching as a way to sort of get around that. I think that's one idea. I think there's other ideas around that, maybe having different thresholds according to your average claim amount. I don't know, I'm just sort of spitballing, but I would say that's where the rub is for us.
Colin?
Yeah, I think, from my boss's perspective, right, like you've sort of heard from everyone involved that like the high level priorities, everyone's pretty much in agreement. I think, now what everybody's focused on is that there are, concerns from payers about cost inflation, administrative costs, concerns from providers about, whether or not patients will have access, especially in rural areas, to a sufficient, number of specialists. And so, it's mostly, I think, at this point, figuring out where everybody can come to agreement on addressing sort of both of those sets of priorities as best as possible. So I don't know that, in my view, there's necessarily policy red lines as much as, just finding out like where the middle of the Venn diagram is in terms of, addressing those concerns.
Okay. Sam?
I think from my boss's perspective, I think we believe we found the secret sauce here in terms of what the solution is. And I think that's evidenced by the fact that the bill we passed, there's no stakeholder who is entirely thrilled about it, I think, and that's a compromise. So I think from our perspective, we feel like we've moved a lot throughout the process to address the different concerns people have had. And I don't think we would want to continue to move by perhaps not having a threshold or further lowering that threshold. So I think that is a concern for us in terms of, adding additional considerations to arbitration. Certainly, at least there is agreement on this stage that bill charges is not one of those considerations. So I think for us, we feel like we've moved a lot. We've come to a compromise among a very diverse group of opinions on energy and commerce, and that we feel like that is the best path forward.
Okay.
Yeah, Chairman Alexander, I think would say that he doesn't think that there is a ton of space between where the certain entities are. That's talking about internal stakeholders being the House, the Senate, arbitration fans, benchmark fans. There is a healthy dialogue taking place, and that we're much closer than the industry stakeholders would have you think from the outside. There is a subset of physicians who have been extremely constructive in helping contribute to the dialogue. There's a subset of physicians that have been extraordinarily destructive, and I think that those are the ads that you're seeing that have backfired to a certain degree. The same is true with the payer side. I mean, there's a subset of employers and unions and healthcare plans that have been extremely constructive. There have been a subset that have been extraordinarily destructive. So on the Hill, you know, it's been our job to kind of operate under the noise and be as pragmatic and consistent and even-tempered as we can to take a structured approach towards resolving this. There is one difference that I would be remiss if I didn't point out, and that's air ambulance. In the HELP passed bill, we do require that air ambulance be subject to the ban on balance billing and also subject to the median and network rate. And Chairman Alexander personally feels that it is no longer time to study this issue, that it is time to act on this issue. And, you know, there have been jurisdictional challenges in the House and in the Senate. But I got to tell you, I don't think when Bill's daughter or child, it was your daughter or son, got that surprise bill for $60,000, they said, you know, if the Transportation Committee and the HELP Committee could just get together and help my child not get a $60,000 bill, that would be, you know, the best way to go about this. They want Congress to work together and to provide solutions and real results, and that's what we're aiming to do with air ambulance.
Okay.
Yeah, I think just as Buck has, over the last several weeks, inherited a legacy item for Chairman Alexander over the last 48 hours, I have now inherited a legacy item for Ranking Walden. So we want to get this done, and we're in a lot of good, productive conversations with both stakeholders, but really members at this point. I mean, it is down to member-level decisions. I think you know when you get to a certain point, it's enough sort of feedback and time to act, and we're getting to that point. Yeah, and so I think we've been in a lot of good, productive conversations, both in the House and in the Senate with Senator Cassidy and some of that group, and we want to get this in law. We want to get it right.
Great. All right, I have time for a question in the back. Hands up, glasses, right there. You got it. Go ahead.
Thanks.
Quick question.
Laird Burnett with Kaiser Permanente. And Buck kind of answered part of my question, but I wanted to ask about air ambulance because it's the source of some of the most eye-popping individual bills, and B, it can actually have a systemic effect on the ability of health systems to operate in certain geographies. I mean, we've had issues in Washington State that have made it difficult for us to operate in parts of the state there. So I wanted to ask the rest of the panelists how deep the commitment is to including air ambulance in this thing in the end.
Okay, speed round, air ambulance.
Yeah. As long as it's done right and accounts for the differences in the market, we're certainly open to it.
Yes.
Yes, I'd say we're open to that as well.
Yep, ditto everyone else's comments.
We didn't have it in our original bill, but I think my boss would, support a solution to surprise billing. I think with the same caveat that we want it to be a fair solution. I think one thing I'll add, just even in air ambulance, you see how hospital systems who may own an ambulance company
are different than a
they're different than freestanding insofar as the hospital may not care what that rate is that they get on the ambulance because they know they're going to have the revenue from the patient being admitted to the hospital, whereas the freestanding ambulance doesn't have that incentive. So I think it reinforces the need for dispute resolution on the back end to recognize those nuances.
Okay, I'm going to apologize to those of you who still have your hands up and ask you to thank our terrific panel of staff.
I want to thank you, Sheila, and thank you for this great conversation. For a lot of us, this is really uplifting to see staff, bipartisan staff, working in a cooperative manner to address a major issue. Buck, I'm just going to, this is kidding you. You said you worked for Congressman Walden. You moved over, you worked for Senator Out. Now both of them are retiring or leaving the city. Is there any connection?
Well, my coworkers for Walden said you must have had a crystal ball. I said, you realize my current boss is on the same timeline.
Well, thank you again. Thank you all for coming out today. Thank you, the audience. And I guess we'll just have to say, go Nats. That's all we can do.
Thank you, guys. You're welcome. Thank you. Nice to meet you. Thanks very much. You bet.
Thank you so much.